Hello, and welcome back to the VJHemOnc podcast. An article titled Expert Opinion on the Diagnosis and Treatment of Hematologic Malignancies During Pregnancy was recently published in the Journal of Clinical Oncology. And we had the pleasure of speaking with the first author, Daan Dierickx, to gain valuable expert insight into this topic. In today's episode, you will hear about the management of pregnant patients with specific hematologic malignancies, as well as key principles and factors that guide clinical decisions in this patient population. Let's get into our conversation with Dr. Dierickx. Hello, Dr. Dierickx. Thank you for joining us today to discuss the topic of pregnancy and hematologic malignancies. Why is the management of hematologic malignancies during pregnancy becoming a more important issue for hematologists today?
Thank you very much for this question. It's a good question. I think there are many reasons. So the first reason is that we diagnose more patients during pregnancy due to the occurrence of the NIP test, the non-invasive prenatal test, in which chromosomal abnormalities for the fetus are discovered. And sometimes we see an aberrant DNA profile, which after some investigations belong to the cancer of the mother. A second cause is the fact that actually some hematological malignancies, like for instance Hodgkin lymphoma and ALL, are seen more commonly in young patients. So it's not surprisingly that we see them in pregnant patients. So it doesn't mean that we see more malignancies in pregnant patients compared to the non-pregnant populations, but it's just because of the age of the patients that we can see them.
And are there any key misconceptions that you think clinicians still have about treating heme malignancies during pregnancy?
I think the most common misknowledge is the fact that some physicians still think that we are not able to give chemotherapy or other therapies during pregnancy. We now know that some chemotherapies, not all, but some chemotherapy can be given during the pregnancy. Of course, we need careful consideration of both the mother and the baby, but it's possible to deliver the chemotherapy in pregnant patients.
What changes about the diagnostic workup when a hematologic malignancy is suspected in a pregnant patient? And which imaging modalities are considered safest during pregnancy?
So for lymphomas in particular, we do PET-CT scan in non-pregnant patients as a staging device. But the problem is that, of course, this is associated with radiation. So in pregnant patients, we don't use PET or CT for staging. In pregnant patients, we use MRI, so magnetic resonance imaging, which is not based on radiation, but is based on magnetic resonance, as the name itself says. And with this tool, you can also stage the whole body and see in which stage the lymphoma is at the moment of diagnosis. For leukemia, we can do bone marrow punction. So if it's necessary to do a bone marrow punction, you can do it safely in a pregnant patient. For lymphoma and for myeloma, for example, we do those magnetic resonance imaging as it's not associated with radiation, with ionizing radiation to the patient.
Moving now to treatment. What are the key principles and factors that guide treatment decisions for hematologic malignancies during pregnancy?
So our first aim is to treat the mother, of course. If we lose the mother, we will also lose the baby. So the mother is very important. We need to treat the malignancy of the mother as we would treat the malignancy outside the pregnancy context. So that's very important. But of course, there's also the baby. So we have a real close collaboration with our colleagues from the gynecological department to try to have the investigations for the baby, the echography, at the same day as we provide the chemotherapy to see if everything is okay with the baby, with the mother, and then we can safely deliver the chemotherapy.
And how much does the trimester of pregnancy influence treatment recommendations?
It's very important because the first trimester is actually the period of the formation of the organs. So all organs are made during the first trimester. And if you give chemotherapy at that time point, there is an increased risk for congenital abnormalities. So we don't give chemotherapy during the first trimester. After the first trimester, so from the second trimester on, many chemotherapies can be given. Then you have growing is important of the organs, but not the formation of the organs. It's the growing of the organs. And then you can give chemotherapy, not all, but most chemotherapies in a safe way. Of course, we still need to be careful because there is an increased risk for premature birth of the baby or premature contraction in the mother. So we still need to be careful, but it's perfectly possible to deliver the chemotherapy, for example, for Hodgkin lymphoma.
How should clinicians think about newer therapies such as targeted agents, immunotherapies, and antibody-based treatments during pregnancy, where the data may be limited?
The data are indeed more limited compared to chemotherapy, and it's also a different context. So, for example, when you consider monoclonal antibodies, which are often part of immune therapy, actually the first 12 to 14 weeks, there is no transfer of immunoglobulins through the placenta. So at that time, you can give it safely, actually, during the first trimester, but you see that the transfer increases when the pregnancy is growing. So for immune therapy, not for all immune therapies, but for monoclonal antibodies, actually, you can give it safely during the first and the second trimester, but we actually advise not to give it from the 32nd week on, because we know it can pass the placenta, and there are some reports of pregnant patients who received checkpoint inhibition during the pregnancy, in which the baby afterwards develops an autoimmune complication. So it's very important that it's to knowledge that it's actually different compared to chemotherapy, where you never give it during the first trimester. Actually, for the monoclonal antibody, it's important not to give it at the end of the pregnancy, or if you need to give it, to be very careful.
That's great. Thank you for your insights. Moving now to specific malignancies. Acute leukemia is one of the most urgent scenarios. How do you approach treatment decisions when AML or ALL is diagnosed during pregnancy?
So if it's in the first trimester, I think termination of the pregnancy should be considered, because this is often, as you say, an urgent situation. So we need to treat immediately often. So if it's in the first trimester, it's very difficult. And often acute leukemia is often not diagnosed based on the NIP test, but because of the patient has complaints. So for lymphoma, it's often diagnosed with the NIP test, which is at the stage of the start of the second trimester. For acute leukemia, if it's in the first trimester, termination of pregnancy is often recommended. From the second trimester on, we can give the classical chemotherapy, not the new targeted therapy, which is not considered safe in those patients, but we can give the classical most of the classical chemotherapy. But we have to be careful that acute leukemia is associated with some coagulation disorders. So first you need to correct those coagulation disorders. Whether you go to chemotherapy or whether you go to termination of pregnancy, you really need to correct those coagulation problems, because otherwise it can lead to fatal bleeding disorders, for example, in the mother. And then you can give the chemotherapy, but we have to be careful, because chemotherapy causes an increase of red blood cells, white blood cells, platelets. And this is a situation in which you are not going to perform a delivery. So we really need to collaborate with the gynecologist to be sure that the timing of delivery is outside of that window of chemotherapy. So, for example, if the diagnosis is at 33 weeks, we will probably first go to delivery and then give the chemotherapy. If the diagnosis is at 24 weeks, we can give the chemotherapy, which lasts for 4 or 5 weeks, and then we have to see if we can give a second course, or if we have to go to the delivery of the pregnant woman.
How are Hodgkin lymphoma or aggressive non-Hodgkin lymphoma managed during pregnancy?
Hodgkin lymphoma, actually, if it's in the first trimester, most patients can wait until the second trimester, so that's not very problematic. And from the second trimester on, we actually can treat the patient with the classical chemotherapy. We also give it non-pregnant patients. So it means that you can give it safely. There is a long follow-up for the mother, but also from the child till 20 years old, where you see no problems regarding physical or psychological or cognitive development. So for Hodgkin lymphoma, the classical chemotherapy can be given. If it's a combined modality treatment with chemotherapy and radiotherapy, we give the chemotherapy mostly during the pregnancy and the radiotherapy afterwards, because radiotherapy is actually not recommended to give it during the pregnancy. For the new immune therapies, we have to be careful. So the brentuximab vedotin, which is now reimbursed for stage 4, cannot be given during the pregnancy, whereas, as I already told, the checkpoint inhibition can be given, but we should be careful for autoimmune disorders, both in the mother but also in the baby afterwards. For aggressive non-Hodgkin lymphoma, the most classical therapy still is rituximab combined with CHOP chemotherapy, and this can also be given, the CHOP chemotherapy from the second trimester on. The rituximab can be given throughout the pregnancy, but you sometimes see some cytopenia in the newborn, but it's mostly transient and not leading to serious infections.
And how would you approach the management of myeloproliferative neoplasms during pregnancy?
So the myeloproliferative neoplasms, they have the highest risk is also in non-pregnant patients is the thrombotic risk. So those patients need low-dose aspirin. So we give them to all patients unless it's a contraindication. The classical chemotherapy, the low-dose chemotherapy, the hydroxyurea is not recommended, but it's mostly also not necessary in those patients. So for example, if there is a young patient with a polycythemia, you can do venous sections to bridge the pregnancy. But the most important in myeloproliferative neoplasms is to give low-dose aspirin. In the CML, which is also a myeloproliferative neoplasm, so the chronic myeloid leukemia, we can give some tyrosine kinase inhibitors. So imatinib and nilotinib are safe from the second trimester on, whereas, for example, dasatinib is not safe because it's transferred through the placenta.
Finally, multiple myeloma during pregnancy is rare, but when it occurs, what are the major treatment considerations?
I think this is the most difficult one, because myeloma can be aggressive, and it's fortunately it's very rare during pregnancy, but it can be very aggressive, and then when we have to treat it during the pregnancy, we have to go back to our older treatment with steroids, with some chemotherapy and anthracycline or cyclophosphamide. Because the new treatments which are given for myeloma, the immune modulators, the proteasome inhibition, and so on, they are at this time, because we don't have enough data, are not indicated during the pregnancy. So here, I think this is the most problematic, but fortunately it's very, very rare during pregnancy. There we still need to go to older treatments. So their termination of pregnancy should be discussed with the patient as well.
Although the understanding of how to manage patients during pregnancy is clearly improving, what evidence gaps or grey areas remain?
Yeah, I think the most important is the introduction of the newer therapies. Hematology is a field which is developing very, very quick. So we need to see whether those new therapies can be incorporated also during the pregnancy, but therefore we need some more information on placental transfer of those therapies. What effect do they have? And the second gap, I think, is we now have follow-up in children until 80 to 20 years, but what we don't know for sure is whether getting chemotherapy during the pregnancy for the baby, whether this has effect on fertility later on during life, or even on secondary malignancies later in life. We don't have any arguments that they are increased at this moment, but we still need some longer follow-up.
And what advances do you think could most improve outcomes for pregnant patients with hematologic malignancies?
Yeah, I think the new treatments. I think for Hodgkin lymphoma, for example, I think we don't need that much new, because they are really doing well, both the mother and the baby. But for the new treatments in acute leukemia and in myeloma, for example, we really need to incorporate them in the treatment.
Finally, Although most hematologists will likely only encounter these cases very rarely, if there's one message you'd want them to take away from this paper, what would it be?
Yeah, I think the most important, there are actually three messages. The first is that we can treat a lot of patients, so we have insights. But the second, and that's also important, we need to do it in specialized centers. For example, in Leuven, we have we treat together with the gynecologist. So we really see the patient together. When the patient comes for the therapy, we see them also together. We see everything is okay with the mom, everything is okay with the blood of the mom, everything is okay with the baby. And then we decide together, we're going to give the chemotherapy, we're going to proceed. If it's not safe, we have to reconsider. So it's very important to have experience both in the hematology or the oncology setting as in the gynecological setting. And the third one is that, the treatment should be in specialized centers. That's a bit, together with the former, that if you only treat one pregnant patient in 5 years, I think it's better to refer. And there is also there is the international registry, the INSIP. It's a kind of a platform in which actually every pregnant patient can be introduced by the treating physician, and the treating physician can ask advice. We have a patient, for example, 40 weeks pregnant with that malignancy, that stage. How should I treat these patients? And then in the INSIP, it's called the APSIP, is an advisory board, which actually consists of members of all disciplines, hematologists, gynecologists, neonatologists, radiotherapists, and so on. And actually, in 2 or 3 days, an advice is given. So we are treating this. We would recommend to treat this patient like this. So it has the register has actually 2 aims: to help physicians to treat their patients, pregnant patients with oncological diseases on the one hand, and on the other hand, it's a real registration tool so that we know how common is cancer and pregnancy.
Fantastic. Thank you so much for joining us, Dr. Dierickx. And that brings us to the end of another insightful podcast episode. Thank you for tuning in. If you enjoyed it, don't forget to subscribe to our podcast on Spotify, Apple, or Podbean so you never miss a new episode. Also, make sure to follow us on X at VJHemOnc to stay in the loop. Until next time.